Hello and welcome to Elroy's Expert Exchange. My name is Rachel Cash. I'm the founder and CEO of Elroi, and at Elroi, we believe access to data can help solve some of the largest problems we are facing in the future. At Elroy's Expert Exchange, we spotlight leaders who are transforming their industries that are delivering on the promises of the future. In this session, we sit down with Ramon Llamas. We met him here in Durham, North Carolina, and he's been a friend of the startup. Currently, he's working with the startup who's at the intersection of health outcomes and working with social services and connecting them in a unique way with technology, giving the citizens access to housing and other underlying support. Ramon has deep expertise in advancing equality at both the state and national level, working to reform healthcare and building on health equality. He's really at the intersection of system change and intertwining in technology. In this conversation, we sit down and talk through technology innovations. What are the goals of the future? How do companies and systems work and move forward as we see shifting politics and policies? We will talk about how being better data stewards can help us drive beyond not only coverage for healthcare, but towards more health equality in the future. We're excited for this session and we look forward to you learning more. Thank you. So just to break the ice, can you tell me a little bit about yourself and where your interests lie?
Sure. Yes. It would probably make sense. I got a public health background, and that's led me to health equity, social determinants of health, which has led me to Medicaid innovation, which is my kind of the past few years has been focused on like how to bring the best, most innovative ideas into Medicaid, because it's less of a focus for the country. Is there a lot of background noise? Sorry.
No, you're good. You're good.
Um, yeah, so Medicaid innovation, I think that there's a lot of room to improve health disparities, health equity issues, and there's a lot of, at least currently, there's some financing from CMS and the federal level happening. So that's the exciting thing, and I'll stop there.
Okay, perfect. Yeah, so you've started to bring up a couple things that we're really interested in as especially as we get into getting more informed in this space. So specifically, would you mind just giving us and the audience an understanding of what health equity looks like? What's your view of that is and how it's evolved through your work? And then we'll get into what CMS is, which is Centers for Medicaid and Medicare in the United States, and we'll talk about that. But just what's your understanding of health equality? How's that evolved through your work?
Yeah, I mean, I think it's equal access to not only clinical but like social services, and meeting social needs. So social determinants of health, housing, food, transportation, economic security, environmental safety, like all these things that are more, I guess, influence health outcomes more directly than the actual clinical services, which is hospital visits and treatment. Um, so coming from a public health background, trying to figure out how to prevent a lot of these things from happening or catching diseases and illnesses earlier on. And health equity to me means equal access to all these things and the opportunity to thrive for a lot more of our populations rather than what's typically happens is a more affluent audience or a more affluent population.
Okay, perfect. Yeah. And so we've seen as we've worked in this, as we're starting to get into this space, or as I'm starting to get into this space more, we start to feel the direct impact of more specifically state and local governments being impacted by the reduction of Medicaid and Medicare from the federal level. Just how has this been evolving in your work, especially as you see that there's more fun or different funding coming up? Like, how does that work into this healthy opportunities for your health equality for you?
Yeah. So one of my main projects right now is I work with a social impact startup called Forward Slash, and we are a direct service provider for Medicaid MCO, so Medicaid managed care organizations, and how they work is a per capita basis, right? So they are responsible for paying for services, broad range of services for their members, Medicaid members, and so usually it's at least 10,000 patients at a time. Um, but I think the opportunity there is focus on prevention, right? Because they don't want to spend a lot of money on each patient. And so, how do we prevent high cost care from happening? How do we prevent ER visits from happening? And so, I think, yes, there are cuts from a Medicaid standpoint, but I feel like if we are pairing or at least um, bringing about solutions that are also saving money, reducing high cost care, improving quality. Um, I feel like the administration at the federal level would at least be open to some of these evidence based cost saving measures, interventions. And so that's the exciting part is how do you navigate a pullback of Medicaid funding and supplement it or replace replace it with really innovative strategic initiatives like ours.
Yeah, so you're in the reimbursement vein with this the startup you're with. Is that where you're like if it's a Medicaid? Just explain how
It's
you guys get
yeah,
into the process.
sure. It's actually it's not a reimbursement model, so it's a straight relationship, a contractual relationship, business service provider to Medicaid MCO. So MCOs, like I mentioned earlier, they contract directly with the state. The state gives them X amount of money per patient per year, and then the insurance company, the Medicaid MCO partners, they give us a per member per month to um, do care coordination, advanced care coordination, complex care. I believe it's called complex care management. Um, and we work with nonprofit and mission-driven organizations to provide the housing case management and the food benefit, which is a national vendor currently, and then a transportation provider, which is not, I guess, which is separate from non-emergency medical transport. So um, we act as like an intermediary that have partners that provide the end user patients these services. We also act as a landlord because what we use is a corporate leasing model and we sublease to the patient. So we're also streamlining the process to get patients that can't afford and can't get housing by themselves, a streamlined process to get into housing, stabilizing them very quickly in a matter of weeks. And then, like I said, there's case management that one of our partners provides, and we do wraparound services to make sure that they're making their appointments, they're looking for jobs, or they're doing all the things that each person or each patient wants to do and is part of their year-long objectives.
Okay. And so measuring outcomes in those objectives, right now, how are you measuring those outcomes? Or are you looking at biomarkers? Are you looking at, or is it really readmission at the hospital level? Is it
Yeah,
reducing cost to the system? How are you guys
yeah,
measuring success?
good question. So since our direct, I guess, partner, like financial partner or customer is Medicaid MCO, their main metrics that they want is number of days housed and number of, I guess, how much ER visits or high cost care that we prevented. And then they look at total cost of care. So before I joined Forward Slash had a pilot in West Virginia. And essentially that year-long pilot showed through the claims kind of auditing process, it showed through the cohort an 83% reduction in ER visits, leading to a 50% total cost of care reduction. And these are the highest, most complex, I guess, the patients with the most complex social needs. They essentially rank them, right? And we take on the most complex patients and we have these outcomes with them. We're hoping to move into clinical outcomes once we start partnering with health systems, but we haven't gotten there yet.
Okay. And so what is that? So you were in Durham. That's how we met. So what is the population difference? You the from being in West Virginia. What are some of the things you're considering? Because those are different complex population, rural populations, and
Sure.
in difference between, I would say Durham has our rural parts. We're pretty spread out and probably not the best bus system, but relatively urban, right? So the demographic may be a little different. How's that been different as you've been in this space?
Yeah, well, so I jumped in for the Northern Kentucky market. So we're in the Cincinnati metro, but
Okay.
I do from what I've heard, the West Virginia was I guess it was more rural, but is also in a city environment. I think there's same issues of housing, or sorry, like housing supply, transportation. I think jobs were a big thing, and so if people were willing and able to work, there was not a pipeline for jobs. From our context here in Northern Kentucky, um, we we like vetted housing units that were close to a bus line, or like closer or walking distance to most of the city. And it's a very compact city here. So I feel like there's a lot of advantages to being in a more urban environment versus I don't know if our model works in a rural setting, but I do think how we approach addressing unmet social needs and this holistic model of um, housing, food, transportation, and other social determinants of health. I think that's the only way to get actual outcomes within a year time frame. So we could also talk about why insurance companies don't get or health plans don't get a lot of results with certain SDOH interventions like food, for example, because they have to find um, that outcome or the positive ROI in a year time frame, and usually that's a lot harder if you have like housing, for example. If you don't have a housing stabilized housing situation, I don't think you could get any positive ROI with just the food intervention alone. So we're trying to tackle that in at least two or three key areas, and I think we're doing well in that regard. Like I said, we're not really looking at the clinical side of things, but um, we are at least they're not at least our patients are not falling through the cracks from a navigation standpoint.
Yeah, yeah, that makes sense. So a little bit about your background and what how we met. You were more in the food insecurity space, and access to food, specifically working on your own startup with access to food and improving the foods like life cycle essentially across for the communities. And we met on that. How are you integrating that into this new startup, and what, but besides housing, so it seems like housing is a lot of what you're working on, but how is that of you that you're viewing that?
Yeah, and I think when I joined forward slash team, they already had a national vendor um, already kind of as a partner. But as kind of our work evolved and as we talked to our patients were telling us, hey, this solution is not enough, and we're not really utilizing the solution. And so it's I guess my role locally from a food standpoint has evolved to how do I find a local solution that better fits the needs that they have, which is, hey, some of them don't want to have to take stuff from a produce box and prepare the meals because they're just coming out of housing insecurity, right? So how do we meet them where they are and gradually get them to where they want to be, their preferences? And so we're working with a couple local organizations here that one can give shelf stable and produce items. And then the secondary thing is ready to eat meals that are both nutritious or healthier, and also easier to manage, and very they have a whole culinary team that's repurposing or redirecting food waste. So it's a huge social impact kind of play for them, and for us it's a win because it's a local organization that we can support through our contracted dollars, right? So um, also spurring local economic development, which kind of tied to my original concept that you and I um, had met previously and back in Durham.
Yeah. So I'll pivot a little bit and want to talk through the policies that we're seeing in action. And I know we've skirted around this. We've seen a change in administrations. Um, what barriers have you seen when trying to transition to an equity focused health outcome, right? So we're looking for social determinant status and largely in systems for Medicaid and Medicare, and how are you guys approaching these barriers, because there is a shift happening.
Yep. Yeah, and so I think that's a great question. And this is probably advice that a lot of organizations that work in social determinants of health or health equity need to start reframing or reshifting their how they describe it. So I think for us, right after the election, we started to tell our story from a very much cost savings approach, right? So this is not only getting saving each the system money and our health plan partners money, but it's also getting the outcomes and also helping save other sectors money. For example, if we have justice involved um, individuals that are patients that are also Medicaid patients that are also X, Y, and Z, um, collectively we're getting that impact and then sharing that savings through various all the other sector partners, right? So it speaks to the interconnectedness and intersectionality of identities. I think when the administration talks about a Medicaid patient, they're not thinking about, oh, they are also a veteran, or they might also be justice involved, or they might also be other characteristics and other identities. And when you cut one thing, that leads to impact in other sectors. And so only looking at one side of a person or a potential Medicaid patient's identity, I feel is very short sighted for a specific, win of budget cuts, right? Like I think the cuts are going to result in worse outcomes and worse spending later on, just because you're going to have folks that are not going to be insured anymore. If they roll back the Medicaid expansion in certain states, you're going to have people that fall through the cracks and essentially can't get health care anymore. And that'll impact all the other systems and all the other sectors. So I feel like it's going to be more expensive in the long run. But um, I guess back to the way we are approaching these cuts is we are going to continue working directly with health plans saying, hey, this isn't a health equity play. This isn't a X, Y, and Z play. It's like, hey, we're going to save you money. And that's the bottom line for them. So I think we're going to continue on our focus on business model of like, hey, we are impacting your bottom line in a positive way. Plus, guess what? Also the consequence is your patients, your beneficiaries are actually benefiting too. So
Yeah, that makes a lot of sense, especially with reframing the business case to the providers, that this is essentially optimizing resources and you'll have less funding needing to be used on these populations. I think that is something that a lot of organizations need to think through to get to the goals that they have. What kind of data infrastructure do you see needed as we move forward? So right now you are working with a couple of groups to help with the outcome. So you guys are managing the housing situation internally through your own tech stack. I'm assuming that you're being like a help facilitating the leases for your patients, and then you're working with the national provider to provide food. How are you guys working with the data that needs to flow across these systems and getting informed consent? How are you addressing that?
yeah, that's a great question. So I guess before we started seeing the need to develop a platform that essentially plugs into all these different sectors, um, we have been helping our nonprofit partners essentially organize this data themselves, right? And I think before all this started, what happened was there was a release of information in between all. There's agreements between the patients and all our partner organizations, and then we have coordinated case management calls either biweekly. I think now we switched to weekly, but what happens is we go each patient by patient weekly and say, hey, here's what's been happening. and it allows our partners both on behavioral health side and primary care side and housing side to all talk to each other, um, just to avoid any unnecessary things that might uh, slip through the crack. Um, from a tech stack platform or side, I guess, perspective, we've seen that all these different systems, like for example, the homeless, I think it's called the Homeless Management Information System. It's a requirement by HUD for these organizations to have that service software, and then food banks have their separate software and client management systems, and then healthcare, obviously, EHRs have separate systems, and so we're seeing the need for data to be able to be pulled from each of those places and like being able to talk to each other, because the case that we're trying to make more broadly is we can kind of see the dose response, right? So if we say patient, let's say you're a patient, and we say, hey, they have been intervened from a housing standpoint, they have been intervened from a food standpoint, and they've been intervened from a healthcare standpoint, and we can see the investment there versus potential savings and their outcomes at the on the, I guess, on the other side of it. So I think we're trying to correlate using this structure of integrating data um, to to make a case for either city or state government to say, hey, this is a per resident um, kind of budget that we're hoping that you can, that's impacting kind of the state level, right? So it's not just, I guess the traditional way has been looking at each of the different siloed systems, and now we're trying to say, hey, from a broader social impact perspective, this is the outcomes, and these are the potential cost savings that we're helping with. So I think it's a big challenging task, but and you're in, you know, data is in your world too. So I feel like this is where the field is going. Um, it's just I don't know the state of how everybody's looking at, I mean, everybody's looking at technology and tech stack differently and data.
Yeah.
And so it's just really about the perspective. And I think you guys align, I mean, your Elroi aligns with kind of forward slashes mentality of how do we do this so that it's actually making an impact rather than like, how do we do this and continue, you know, our lifetime of SaaS software
Yeah.
services,
Yeah.
right? Like we're
Right.
not
Right.
trying to just like make VC and investors super like wealthy to cash
Yeah.
out. So this is more about the impact that we're having with the patients themselves.
Yeah, and it's something that we're hyper aware at. Even as I build this company, I'm hyper aware that there's this local nuance that you really need to understand when you're building these data stacks, or understanding these communities. And what you guys have really interesting insights in is that your individual like patient populations are really digging into that data, and being able to cross populate that data individually is different than when we start integrating technology into these stacks. So that's something that we've fought with, is what's the ethics around that, and then how do we make sure that we continue to have the nuance of understanding in those communities. And I think you guys are really forward thinking and starting from these small cohorts that are large, and you get up to the local and then state level, and that's how you move across these systems. I think that's a really powerful way to maintain those local nuances. um, any other context you would for recommendations for other organizations looking to scale the same way, or looking to make these changes? For example, if you're, I mean, every state will have to do this. So, other recommendations that you have as they move forward.
Yeah, I mean, I think more broadly is I think you have to start with the end user patient, right? Like if it's a Medicaid patient or if it's whoever the end user customer is, like co-design a solution with them, right? Like really try to understand, even do like if you can, like shadow that person or shadow as many people as close to the problem as possible, because it's easy to make assumptions and then like build based on those assumptions, but until you validate that through a specific like use case, like for example our food program, we're like, oh yeah, it sounds like that's what they want, and then we talk to them further and like, no, we don't, we give away the food, and so when you think about certain like policies like food as medicine policies, and you wonder why some of the data shows like it's not really improving health outcomes, it's like, well, because are you providing the service that people want, right? And you have to meet them based on that local context of, I think we need to start moving towards like personalized. How do we personalize it, or at least give our patients more options rather than saying, hey, everybody gets a produce box for 30 days. I mean, I don't think it works for everybody. So um, that's a potential solution that if you can offer, if you're a startup or a nonprofit that offers food solutions, for example, if you can offer a variety of options, I feel like that could get you closer to the outcomes that everybody wants, is that the healthcare system stakeholders really want, is, hey, either clinical outcome or um, cost savings outcome, right? So bottom line, and I guess more speaking towards like nonprofits and social impact organizations, they need to start speaking healthcare language, right? Like the service provision that they're doing is healthcare related, but if they don't speak healthcare language, then they're never going to be able to, I guess, get earned revenue and make longer term financial stability for their organizations.
Yeah, that's a great advice, especially as we move forward. One of the other questions and things that you brought up previously was that we have a lot that you're dealing with a lot of at-risk populations. So you have justice-involved populations, potentially other populations that may not want their data being used or shared across these agencies, specifically your state agencies. Have you guys started thinking about that? What have been your approaches? If it's proprietary, don't share, but like what are some of the practices that you're starting to think about, even just individually as we move forward in a more
Yeah,
at-risk case?
I mean, I think that's a great question, but I also think that if they, I mean, I whenever I have this discussion with any, not necessarily our patients, but just any like average person on the street or something about data sharing and data privacy, is if you're using any social media or Google or anything on your smartphone, essentially you're giving up to your data anyway, right? Like it's, you don't know what's happening with data that you're
Right,
using from the internet, or even like at coffee shops using your laptop. Like all these
right.
things are already tracking your behaviors and usage. And so if you're, if you know that's happening, I don't know what the difference is between you consenting to sharing this type of data, especially knowing that it's going to be not identifiable, right? Like that's, it's a HIPAA violation if you have like PII anywhere in there. And so um, I think it's just a, but I think it also moves towards what kind of trusted relationships do you have, right? And I think that's what we're building from a, um, I guess from the start, is we're working with organizations that have been in the community. They can form trusted relationships. They have the case management expertise, and so going to them and saying, hey, potentially if we took the next level about this data sharing, here's what this partnership could offer. And I think potentially if we can compensate them, that would be the ultimate. But right now, I feel like we're meeting their social needs, and I think that's enough for them to be part of this and like opt in. So um and that's a broader conversation of like, can we use like meeting unmet social needs, addressing unmet social needs as a way to encourage and like I guess foster two-way dialogue between a lot of at-risk populations like you mentioned.
Yeah. And so we think about this a lot, and we have these expectations. I think we have social contracts that we're in as societies, and that we've continued to fail a little bit with social needs. There's generational people who have been either housing insecure or food insecure. How are you or thinking through overcoming these thoughts? And that is like, for example, we work with in the VA, right? And there's a historic view that there's a population who will never go get their VA benefits because of perception and a failure of meeting those expectations. So when we think about these social needs in these populations, have you guys thought through not only having these trusted partners, but overcoming, I would say, the failures we've had with health outcomes?
Yeah, I mean, so I, a lot of that, um, we defer to our local partner that has dealt with housing. They're the experts in case management.
Hmm.
So they have a screening process, and they essentially figure out whether or not um, some of the folks that are going through intake would succeed in our program. And I don't know. I think it's unrealistic to think that we can try to help everybody, right? Because they have to meet us
Right.
halfway, and a lot of the kind of contractual agreements with them, or at least commitments they have to each other from a case management standpoint and to the patient, is this is a two-way dialogue. You're going to have to do your part of case management weekly, and then you are guaranteed housing. I mean, it's not a huge lift, and at the same time, if they can't do that, then there's honestly, like, we're not going to force anybody to do anything that they don't want to do, but at the same time, we can't continue providing resources for folks that don't want to at least be somewhat accountable to their actions and behavior, right? So I think there's a partnership that we're working towards, and fortunately, they already our partner Welcome House. They already have like standards that they've and policies that they've used and employed for probably 20 or 30 years now, and they're getting their outcomes that they want, and so um, they're able to vet for us, and we're kind of just the intermediary between health plans and our community partners here. So I think there's definitely room for folks like us, right? Like,
Hmm.
and other organizations, if they want to start kind of being this middle layer, like they know how to talk to various stakeholders and align interests and align motivations and align just architect like a collaboration. I think there's a lot of room because we are active in maybe a handful of cities, and there's so much. I mean, Medicaid's everywhere, right? And Medicare and Medicaid, we
Yeah.
haven't even talked about it. So, yeah.
So I'm getting, when we look forward, because Medicaid is everywhere. There's that millions of people that rely on it, and and we're starting to see this ebb and flow and the pushing on the system. But what not that we need Medicaid or Medicare to break, so hopefully that Congress does not do that. That hopefully this does not speak to, but what parts need to break to give a window to opportunity to make the changes? Where do you think we're at a stress point that we should be seeing the needle move towards something new?
I've been thinking about this, and I think it's as easy as a policy change of, can you do 3 to 5 year contracts for health plans, right? So instead of having to do an annual thing with all the admin burden and all the marketing and all this stuff, can you just say 3 years? And
Hmm.
so at least there's a good focus on 3 years for a population, and then they can say, hey, we can invest all this money, and at least in year 2 or 3, we can see that we prevented X, Y, and Z. But right now, everybody's so under the gun of like proving out their solutions in 1 year, and I feel like it would give everybody a little bit of time to not only plan and co-design better intervention at the ground level, but with patients, but also allow them to evaluate and get the outcomes that everybody wants, right? So everybody wants good outcomes, but I feel like health plans are seen as the bad guy because they're trying to run a business, but at the same time, it's like, hey, they they're abiding by all the regulations, right? Like, and if they don't, they are penalized, and so there's a fine line between. It's called a medical loss ratio, MLR. So there's a fine line between making profits and staying within the MLR, and then essentially being in the red and like losing money, right? So there is a
Right.
very fine line, and the closer we can get with data and like predictive analytics, and the closer that we can get to actual engagement and patients wanting to be proactive, and um, I think the closer we will get to a favorable situation for everybody. Unfortunately, I think we're at a point where insurance companies they're able to, even if they have losses, they're able to they have resources to make up for those losses, right? And they have multiple markets. versus on the patient side, it's that much more magnified, right? Like if you don't get all your, you know, healthcare, or if you don't get all your things aligned in any given year, essentially you could be hospitalized, or like you have very poor outcomes, or be homeless, or any of these things could it could essentially break you on an individual or micro level. Versus these huge institutions, they can withstand a lot of things, right? So how do we get like a balancing point? And I think the easiest way to do that is just getting extending this time, even 2 years. I feel like would buy folks, healthcare providers, folks like us, a little bit more time to be able to meet those outcomes, successful outcomes, and continue these programs. Otherwise, you keep starting and stopping. And yeah, now they're thinking about. I mean, I know food is medicine is trending, but if they don't continue getting the better outcomes than what they're getting right now, it's I don't know if health plans are going to continue doing this stuff, right? So yeah, that's number one. Number two, I feel like if we can get out of the, I feel like there's these all these different financial incentives don't line up, right? Like
Hmm.
when you're thinking about healthcare, it's like why can't we just provide all the things that a specific patient needs to get the outcomes we want? Like we're not getting anywhere close to value-based care. We talk about it a lot, but I don't think there's a has been good use cases for value-based care. um, on a broader scale. I think there are certain situations with certain disease states that value-based care works, right? So high specialty, high cost care, value-based care, outcomes-driven care, um, huge. But when we shift, when our focus all is mostly on specialty and less on primary care, or funding primary care and funding social services for that matter, um, I think that's where the broader population just suffers, right? So Medicaid, Medicare, all need primary care as a driver. And primary care innovation, there's a lot of primary care innovation models out there, but a lot of them don't work because they're not funded um, well enough. And so, yeah, there's, I think those two main issues for me. And then I don't know if you want to talk about the future, but I think the future could be, there's a potential for it to be really good or really bad, from an
so
innovation
so
standpoint.
I'm interested in both your thoughts on the potentials of and where you think the decision point would be. Where would be the critical
Yeah.
point?
Well, so I think the best case scenario is that a lot more, we find a great use case for AI in Medicaid innovation, and a lot of smart minds are now hopefully turned towards Medicaid and trying to actually solve that problem rather than the admin problem, right? So all the AI solutions that I've seen that are taken off are, hey, how do we make billing better, or how like
Yeah.
whatever it's called, RCM, revenue cycle management, like
Right.
that's not really going to drive outcomes. It's just going to
Hmm.
help you do the business of healthcare. Um, so I'm hoping AI. I think the best case situation is we move towards like personalized medicine for Medicaid patients, right? So this is already happening in the private sector, self-pay, like executives. It's called longevity medicine. Executives are paying these super smart teams of physicians, genetic counselors, nutritionists, and fitness professionals to say, "Hey, optimize my health," because my
Right.
goal is to extend my life so I can keep working and being productive as an executive, and I'll pay you whatever you want.
Hmm.
Meanwhile, the people who actually need this stuff, Medicaid patients, are denied coverage, are getting kicked off of Medicaid, like all these things. It's like, who do we need to focus attention on? If we can just align those financial incentives a little bit better, I think that's where AI can kind of step in and fill the gap between the rich and poor. The worst case scenario is that AI and all this new kind of generative AI technology increases the disparity gap. So from an education standpoint, if there are certain families and kids that are learning on AI and using that to optimize their learning, and then able to, I guess, save time to do extracurriculars and build their resumes up, they would continue to go to college and Ivy League institutions and having great career trajectories. And then folks who don't have, you know, uh, role models or parents that understand this technology and have parents that encourage them to use it to help them uh, get through education, or if they're working jobs during high school full time. um, I feel like those little, what didn't used to really matter as much before, like if it was only a financial difference, I think you can still make that up with hard work. But right now, with the optimization of AI, the potential for I feel like the disparity is just going to grow, and that's, I think that's my worst case scenario. Is like, oh shit, we are now trying to reduce health disparities and opportunity disparities, but now it's just so much wider, and I think it'll be a harder challenge. And I don't know if we'll be able to honestly like get back from that. That digital divide is like exponentially growing, right? So
Yeah. And it's
yeah,
interesting. So I know we both have talked to, or at least looked at in the past, the digital equality grant programs and applications there. And a lot of the organizations that did receive funding were libraries and very on a local level. But it seems that I'll have to look at the data. So we'll put it on our one of our side projects is really around what's the outcomes of some of those digital equality opportunities, and how does that, to your point, really create this cycle that, as this interconnection between health, data, or and this digital world, the disparities will continue to increase. And I think a direct relationship is, do you have access to your health charts? Will you even use this? If we buy, if a organization provides this to you, will you have the knowledge to be able to leverage it appropriately? It creates this all these other nuances that are not, which you're already dealing with, which with our populations they're already dealing with. You have a whole bunch of other, like housing, food, do you have internet at your house, other things that we're worried about. So I think that's a dystopia that we're have to be actively aware of.
yeah. So hopefully we can go more towards like the best case situation,
Hmm.
which I think. So I don't know if you and your audience knows of Holly Teco, but Holly Teco has a podcast called the Heart of Healthcare. I listen to it weekly. She's been bringing on a lot of great guests, and it's the whole thing is about how to, uh, I guess, improve healthcare for everybody, not just people that can
Afford it.
avail of,
Yeah.
yeah, of going to
Cool.
Whole Foods and like focusing on lifestyles and work life balance and all that. I mean, entrepreneurs, I feel like, don't know what work life balance is, and I think
Hmm.
I've heard so many different articles. Like I think Mark Cuban and somebody else, they're just like, if you want work life balance, like you work a 9 to 5 and you're an employee, but if you're a startup founder, like what does that even mean? And it's your life. I mean, it's just being able to shift on the fly, and yeah, you can definitely have time and autonomy to take breaks, but at the same time you're going to have to always jump on the next opportunity. And I don't know, I mean, I feel like entrepreneurship is a personality. So um yeah.
It's a personality trait we'll add to it. Like, you like hard things and being uncomfortable all the time. Great. This is the field for you.
Yeah, no, it's and how do we understand our patients that way, right? Like how do we
Mhm.
kind of get into that level of like, all right, so this is how to push, or this is kind of how to motivate them a little bit more, or
Yeah.
do we need to take a more passive approach? Do they need a more regimented approach? I think there's way more we can do. It's just I think our partners that are direct service providers, they are burnt out. I mean, they're,
Hmm.
you can tell them all this new innovative stuff that's happening and new opportunities, and they're just like, hey, we're just trying to survive. um, we don't have time to think about like what we can do to improve. Like we're just trying to survive, which I think that's also another technology potential, um, partnership there. So
Yeah. Awesome. Well, leaving a couple minutes to just give a little bit of your bold 5-year vision. I know you kind of laid out what you think the two possibilities of the future may look like if we aren't careful about technology. But if we were get it right, if everything was the way that you envision would be right, what would you like the outcomes to look like 5 years from now? That could be these big shifts that could happen in the next 5 years.
yeah, I had a conversation about this yesterday, similarly. So, um, I guess there's this startup that's working on geospatial mapping,
Mm-hmm.
um, and I think you would probably appreciate this, like data. We've been talking a little bit about data right now, but like getting on a really personalized level with data with our patients. How do we co-design and have them essentially voluntarily provide us data around health behaviors, but also like geospatial. So being able to really get better on the predictive analytics a little bit from a risk stratification standpoint, but also personalizing it. Like, hey, what is your like? I don't know if we can arm folks with a chat bot, but hopefully they can engage with that in the future, and like for them to have conversations so we can further how do we like really personalize their intervention from a Medicaid standpoint or from a Medicaid intervention standpoint. But I think it's a lot of it. The ideal situation is co-designing solutions with the end user patient. So in my case, I think Medicaid patients, if we can co-design solutions and even co-build companies together, like for example, when we looked at this food as medicine local play, we were like, hey, if some of these folks wanted to work and they just don't have the opportunities, could we build a solution locally and then hire them to actually run and solve like a food
Right.
insecurity problem locally? And they would be co-owners of a company. So the ideal situation 5 years from now is co-ownership of businesses with Medicaid patients and co-design solutions with Medicaid patients. I don't know if we can get there, but I think we're definitely trying. And from our end, we're trying to just get the financing because I feel like financing is always the hardest. And then we can work with programmatic folks and experts to implement the programs. So yeah, I think there's a lot of opportunity in data. There's a lot of opportunity in co-design, hopefully. And if we can combine the two, then that would be um, the bold vision is how do we create better solutions together.
Awesome. Yeah, very inspirational. It definitely speaks to my heart, definitely for the patients in our communities and making sure that they can get access to the right healthcare, and that could be across the spectrum. And so yeah, I'm rooting for you guys. Would be happy to be a co-contributor to a tech stack, or in probably as I think through it, something that we should be adding as a for thought leadership of co-designing with our demographics that we work with a lot of HBCU students, which also have limited resources, and putting some of our funding behind them as they continue to build. And it's something, as you were speaking, I was like, oh, I'm inspired by this. This is something that we can embolden the next future group of innovators. So exciting. Any closing remarks? Any shout outs that you're interested in shouting out?
I mean, since you're speaking about like student unmet social needs or that kind of thing, there's this group called the Student Basic Needs Coalition. I feel like you guys would have a good conversation. And so forward slash, we're doing work in Northern Kentucky and Cincinnati. We have done work in West Virginia, North Carolina, Washington State, California, Bree City down in Durham. We're trying to really position that as a community care hub. Um, 60 plus mission driven organizations there trying to work directly with healthcare. Well, so there's just a bunch of folks that I've been talking to, and I think there's a lot of us. It's just we're not all connected. We're all in our own silos, and so how do we learn from each other and have these kind of conversations and share networks, right? So I think I'm trying to figure out a way to have people that are focused on relationships and like more business development or strategic partnership development talk to each other and say, hey, this is what I'm doing. This is each of us is like sharing what we're doing, and then like proactively can connect if it resonates with folks that they've already worked with or friends of theirs or customers of theirs. Like how do we make this easier so we're not each trying to cold call 1,000 people a day, which is the typical startup life mentality. Is like, oh, I need to just do my metrics of 1,000 outreaches a day, and it's like I don't know if the method really works. And so how do we work smarter collectively and just share relationships.
Yeah, awesome. Well, exciting news. I know our work that you've been doing. We'll tag all your socials and we appreciate your time today. Today, thank you.
Yeah,
And then,
you guys enjoy your weekend, and hopefully we'll be in touch soon and work on something together soon.
right, right. So now that like I'm like your startup, hit up my startup, and we'll we'll figure out how we can work together.
Yeah, your
Awesome.
people can talk to my people. Yeah.
Exactly, which are the both
All
of
right.
us. So perfect.
All right. Talk
All
to you
right,
later.
have a
Bye.
good one.